Today, I'll be speaking on ADPKD and kidney transplant, a surgeon's perspective. All of you know autosomal dominant polycystic kidney disease affects almost 12.5 million people across the world, and probably it is one of the fourth leading cause of kidney failure. And the patients who require renal replacement therapy, either in the form of dialysis or renal transplantation. Typically, it is characterized by bilateral multiple cysts and the enlargement of the kidney, and patient presents either with pain, hematuria, or fever due to cyst infection. And almost 50% of the patients who are developing ADPKD, they will ultimately go into renal failure and requiring transplant. There is no doubt about renal replacement therapy for ADPKD. Renal transplantation is supposed to be the best optimal choice. But the issue is related to the native kidneys. So whether we should do a nephrectomy, when should we do? And probably my today's topic will be more concentrating on this native kidney nephrectomies. So there are three questions to be asked before we evaluate these patients as a recipient for transplantation. So why we should do nephrectomy in these patients? When should we do it? And how we can do that procedures? Why? There are typical indications of nephrectomy. There is a study from Egypt where the number of patients who bled, the cyst bled and then did nephrectomy is the highest among the list. Number two is a pain, which is very intractable and not responding to routine painkillers. Infection in the cyst is another indication, common indications of doing pre-transplant nephrectomies. And of course, space is not that high indication of doing nephrectomy, which probably a decade or 2 decades ago was the commonest indication of doing nephrectomy for creating the space for transplant. So typically, these are the indications for native kidney nephrectomies: when there is a recurrent infections in the cyst, when there is a intractable pain not responding to multiple analgesic medicines, when there's a diagnosis of a suspicious renal cell carcinoma in the kidney, symptomatic nephrolithiasis, and if at all you want to, if you don't get space for the renal transplant or the kidney transplant on either side, then probably this is additional indication of doing nephrectomy. Multiple episodes of bleeding in the cyst is another indication of doing nephrectomy in pre-transplant ADPKD patients. So what is the ideal time? This is the most controversial topic when we should go for nephrectomy. Few institutes suggest we should go pre-transplant. Few studies suggest we should do simultaneous nephrectomy and kidney transplant. And few institutions, they do have protocol of doing nephrectomy if at all needed post-transplant. There are multiple advantages and disadvantages of both. If you do pre-transplant nephrectomy, then your transplant date is postponed. And if you do bilateral nephrectomy before transplant, then probably managing anuric patients is very difficult, because these are the patients who may need multiple blood transfusions because of loss of erythropoietin. If you do simultaneous kidney transplant with nephrectomy, then again the operative time goes up. And if you do nephrectomy and something goes wrong, then probably your transplant gets postponed. See, this is another disadvantage of doing simultaneous kidney transplant. If you do post-transplant, then you are doing the nephrectomy or surgical procedure in a patient who is on immunosuppression. So the additional risk of infection in a post-transplant patient where the nephrectomy is indicated is another factor we should be considered. But there are definite disadvantages also. If you do pre-transplant nephrectomy, then your patient is well prepared during the transplant. So the post-transplant complications of cyst is avoided, like infection in the cyst, bleeding in the cyst. So patient is quite safer in the post-transplant period. If you do simultaneous procedure, it has definite advantage because you are doing a single procedure where both the things can be done together, and it is definitely advantage to the patient, though stressful to the surgeon. If you do post-transplant, then you get a patient who has normal creatinine. Then definitely all the anatomical or physiological things in the body which are deranged because of high creatinine, they come down to a normal physiological things, and the healing gets faster. And the disadvantage, as I told you before, the chances of infections are high because the patient is on immunosuppression. Second important thing is cost. Doing pre-transplant nephrectomy is lesser costlier than doing post-transplant nephrectomy, because operating a patient after transplant is a more costlier affair than pre-transplant thing. Again, the time of nephrectomy, there are various studies. There is no consensus when to do that. As I told you, some institutions they do pre, some they do simultaneous, some do post transplant. There are many studies which do simultaneous approach, like doing nephrectomy and transplant. Again, the indications, drawbacks, and advantages I told you before. When you compare two stage versus single stage, at least study shows single stage or simultaneous transplant with nephrectomy has definite better advantage than doing two-stage surgeries. There is a study which compare pre and post transplant nephrectomy. As far as graft survival goes, it is absolutely same. Complication rate goes, it is absolutely same. And the indications of doing nephrectomy before and after transplant doesn't changes. So the patients who require transplant, the indications remain same for those who do a post transplant. So the indications are same for both, whether you do pre or post transplant. Now it's absolutely a surgeon choice, and there is no single consensus on which is advantageous and which is disadvantageous. Probably the institutions which follow, they follow the things which are there for years together, and they are safe in their hand. So again, indications of nephrectomy, whether you do pre or post transplant, they remain absolutely same. Like the commonest is bleeding, infection, and very rarely you have to do nephrectomy for carcinoma. How you should do it? There are various approaches. The commonest approach is open surgery, because the kidney size is very big, and if the surgeon is not having experience of minimal invasive surgery of laparoscopy, then probably this is the best option. Either this can be done through a typical kidney incision, or it can be done through the midline incision if you have to do bilateral nephrectomies together. Remember, you should avoid doing anything below the umbilicus, where your kidney has to be implanted later on, because any incision or any scar at that particular point of junction or at a particular time of site will definitely create fibrosis, and your transplant surgery becomes more difficult. Laparoscopy is a choice of surgery nowadays. There is a definite advantage of doing laparoscopy, because the hemoglobin loss is less, as there is a less blood loss. Less blood transfusion requirement is chances of less blood transfusion in these patients, because the blood loss is less. Hospital stay is definitely less, and the surgery for the transplant can be quicker as compared to open surgery, because the morbidity of laparoscopic surgery is very, very less. There is definite advantage of laparoscopic surgery, but you have to be very sure about the procedure, and you have to be absolutely prepared for the open conversion, because the space is very limited in nephrectomies of ADPKD patients. So many times you are putting a port, dissecting, you might damage the organs nearby, like intestine, spleen on left side or liver on right side. So you should be very less hesitant to convert into open surgery. Why you should not do pre-transplant or post-transplant nephrectomy? So all the patients who are on having ADPKD who needs transplant doesn't need nephrectomies. That's a new consensus probably, and the study shows the polycystic kidney volumes of this ADPKD kidneys that is significantly different decreases after transplantation, even in patients with simultaneous nephrectomy on other side. There will be reduced in the need of bilateral nephrectomy in asymptomatic patients. So if the patient is not symptomatic before transplant, we should not do nephrectomy, because this kidney usually don't get trouble in the post-transplant period. The recent study found that the rate of volume reduction may be influenced by the shorter time of dialysis and higher GFR, although the type of immunosuppression does not influence the rate of volume reduction. So it is the same in all the patients. So the changes in kidney volume after kidney transplantation in patient with ADPKD, there is a definite decrease in size of the kidneys in post-transplant period, but the duration ranges from 6 months to 2 years. So it doesn't happen immediately. Is there any alternative to do surgery in these patients? Yes, there is an alternative which is not commonly used, but you can do renal vein arterial embolization, which will reduce the size of the kidney, and you can do transplant later on. The only thing is the period between the embolization and the regression of the cyst or shrinkage of the size of the kidney is about 6 months. So 6 months period has to be gone between the embolization and the kidney transplant, because that much time is required to reduce the size of the cyst. So there is another question, whether these polycystic kidney patients can be taken as a cadaver donor. Is it appropriate? There are few anecdotal studies where it is not a series of studies, but there are single cases by multiple institutions across the world where they prefer the patients with cyst in the cadaver. But the only thing is the maximum life of the patient, of the donor, where this kidney is going to be implanted, should be 10 years and less. So because if the new cyst or any complications in ADPKD patients, that happens usually after 10 to 12 years. So the minimum lifespan should be 10 years in the recipients. Development of ESRD following transplantation of an ADPKD patients with cyst size up to 34 millimeter can be taken for 12.5 years. So donor age is the key factor determining the time of transplantation. Younger the donor, better the results of transplant. So to conclude, the ADPKD, the most common monogenic cause of end-stage renal disease. Approximately 10% of the patients, they need kidney transplant. Currently, there is no consensus or whether on when nephrectomy should be done. Is absolutely institutional and surgeon experience based. In the review of optimal timing, the native kidney with individual ADPKD kidney in the absence of consensus underscore the need of patients' tailored approach. Future large-scale prospective trials are needed to order to achieve a better understanding of the disease and the need of nephrectomy and a transplant. Thank you so much.